personalized glaucoma management.
Excellent. Great. Thank you very much, Dr. Al-Naimi, for the opportunity to be here, and thank you, everyone who's attending this morning. It's always fun to to share, and I hope this can be as interactive for us as possible. So during the course of the presentation, feel free to reach out. I think probably there's a way in the chat session to ask questions. And so I don't know if I can see those, but Dr. Al-Naimi, I'm sure can. And so feel free to reach out into the chat session. And actually, I do see the chat session. So if you have any questions while we go along, by all means, feel free to jump in, and this can be as interactive as you'd like it to be. So I'm excited to be here this morning and share, with you some topics about glaucoma management, and so let's see if I can just get this over here. I think that's good. Yes, and so really, maybe let's just start off by, let's see if I can align myself properly here. There we go. All right, so now these are my disclosures. So of note for today, a lot of my OCTs will come from OptoView, which is now VisionX, and I'll be talking about some New World Medical, the New World Medical surgical procedures. So those are probably the main relevant disclosures. I also want to say that in the middle is my mentor, Fred Carlin, who really kind of took me under his wing when I first joined the practice. He's recently retired. And then my friend and business partner, Mike Talone, a portion of today's stipend will go to the Fred Carlin Community Vision Foundation that we established in his name. And for those out there who are mentors, good, congratulations. Try to be a mentor for someone if you are not. And if you are perhaps just getting into the profession, find yourself an excellent mentor, and because it will enrich your life in so many ways. There are a lot of ways to reach out, to continue the discussion. If there's something, that you think about tomorrow or the next few days and you have a question, or maybe you're in clinic on Monday and you have some questions based on, what we talked about, today, feel free to reach out either by email or by LinkedIn, or even, feel free to send me a text. Always happy to share. So let's start off the discussion in this way. How many times have we seen this exact case? And how many times do we place this under the umbrella of, oh, okay, let's diagnose and let's prescribe a prostaglandin? And then what do we do once we hit that point and we're still finding progression? Okay, so here's a case, 74-year-old white female. The referring optometrist is concerned with glaucomatous progression by OCT, IOP, is consistently in the high teens. So this doctor was saying, and by the way, I have the privilege of being a part of both. I'm a primary care optometrist, but also we are a secondary referral glaucoma center as well. So I have the privilege of kind of doing both those things. So this optometrist was concerned by seeing OCT that this patient was progressing, and so sent the patient to us. And the ocular history, the patient had uneventful cataract surgery about 3 years prior. About a year after that, which was 2 years ago, the patient was diagnosed. The optometrist diagnosed the patient with POAG and started Lumigan for the last 2 years. Best corrected acuities 2025, corneal compensated IOP with our ocular response analyzer was 18.2 and 18.4. Tmax was reported to be 24 and 25. Pachymetry is 563 and 571. And corneal hysteresis, a really important factor and predictor for both conversion and progression, was 11.5 and 11.7. So so this is this is the patient, and so we reviewed the previous OCTs, and here's what the nerve fiber layer analysis shows us. And so I'm going to see if I can get my laser pointer. You're probably seeing my laser pointer at this point. But as time goes by, we're seeing a reduction. And real quickly, as we review these OCTs, and of course this is an OptiView OCT, but they all follow the same concepts, and that is, we want to look at the pattern from baseline to most recent, but we also want to kind of get a sense of maybe the numbers, the microns in the most crucial areas, and the most crucial area being, this is the left eye, is supratemporal and infratemporal. That's the normal pattern of the nerve fiber layer, and so we want to make certain that that pattern is not changing as time goes by. Well, look what's happening here from baseline to today. Not only is the pattern changing, we can see some thinning right in this area compared to baseline, but we also can see some thinning infratemporally as well. So remember, glaucoma is a pattern-based disease. If you can recognize changes in pattern, you'll do well when it comes to glaucoma management. And so we can see that this pattern, as time goes by, is changing. We can also, looking at the thickness, the microns, we can see, going from 115 to 93 and going from 87 to 76. And we also can look at our trend analysis. All OCTs have trend analysis really at this point. We can see a declining trend. So despite treatment with Lumigan, this patient, I would agree with the referring optometrist, this patient is progressing. Another important area to look at is the ganglion cell complex in the paramacular area. So this being the macula, we're looking at the thickness around, and we can see, remember, what I said a moment ago about pattern-based disease. This is baseline and this is most recent. Look at what's happening to the ganglion cell complex as time goes by. This red indicates thinning. So we can see that there's definitely change in this, this patient's ganglion cell complex. And the trend analysis also is progressing. So again, we can safely conclude at this point structurally that this patient is progressing. Their glaucoma is progressing. If we look at, we in our main office, we utilize an octopus visual field, which you're seeing here. And we can see that there is a superior arcuate, nasal steps, both superior and inferior, possibly even an inferior arcuate. The mean defect is reduced to 4.4. So I'd classify this as a mild, mild to moderate visual field involvement based on HAP criteria, Hodep, Anderson, Parrish criteria. If you want more information about how I classify visual fields, you can go to my website, MikeCymbor.com, and it has a section on HAP criteria if you want more information about that. All right, so what should we do at this point with this particular patient? Should we use a second drop? Should we do SLT? Should we do MIGS? Should we do a YAG PI? Or maybe should we go right to a TRAB tube? What should we do now? And I gave this presentation to our interns, our fourth year student doctors, third or fourth year student doctors a couple weeks ago. And one of them who might be on this call, on this webinar right now, astutely said, well, it really depends. It depends on all of these factors before I can really tell you what to do next. There's so many factors that go into that question, and I know you're only seeing a piece of what I presented. But is this patient non-compliant? Are they missing their drops? Do they have angle closure or narrow angles or somewhere on that angle closure spectrum? Do they have exfoliation? Do they have pigment dispersion? Are they using steroids? Do they have reverse pupillary block? Do they have traumatic, a traumatic glaucoma? Do they have uveitic glaucoma? Do they have neovascular glaucoma, a case that we just saw yesterday? So many factors go into this, and this is really the gist of this talk, which is to say, we can't just make the diagnosis and lump these patients in under primary open angle, because there are so many little intricacies involved in glaucoma management, and I hope to tease some of those out during today's presentation. So in this particular case, the patient, when further questioned, because we ask our patients, did you get your drop in last night? Do you get your drop in regularly? And most of the time they say yes, even if they're non-compliant. But this is one of the rare cases that this patient said, you know what, I do miss the drops a lot. And maybe I only get them in half the time. And so that was when you know that, and a lot of times, again, they will tell you that they're taking them every day, and they're not. But when you know, when they admit to non-compliance, that can be a helpful tool in your glaucoma management arsenal, essentially. Dr. Quigley from Wilmer, he presented this to the Optometric Glaucoma Society in 2015, which, if you're into glaucoma, that is that's probably, in my opinion, the best glaucoma meeting ever. It's always the day before the academy, and I just never miss it. And what he said was, all things considered, our patients are probably taking their drops 50% of the time. And every study that, every compliance study in glaucoma says about that. Some are a little higher, some are a little lower, but all things considered, our patients are probably taking their drop 50% of the time. The fact that this patient admitted to non-compliance probably means they're taking them a lot less than 50% of the time. So when that happens, I start to think about SLT. SLT reduces pressure about 25% at 3 years. It causes a restructuring of the trabecular meshwork based on the energy that's applied to the trabecular meshwork, and then the phagocytosis process where the white blood cells kind of go into the trabecular meshwork and essentially munch on the trabecular meshwork, opening up the channels a little bit more. There are a few complications that include pressure spikes, inflammation, all of which typically are easily managed. So the evolution of SLT, it's been around for a long time, but in 2015, in this study by Wong and others, said that SLT may be offered as first-line therapy. And a lot of the studies, at that particular point in time, they would all say may be offered. So they didn't make a definitive, like should be offered, but may be offered. And then the LIGHT trial came out, and the LIGHT trial came out in 2019. And what it said was, it took a step further, and it said should be offered as first-line treatment. Should be. So that's a big step in the nomenclature. That definitely ups the ante. The LIGHT trial took place over 3 years. It had, you can see how many patients, about 650 patients. Half were randomized to SLT, half were randomized to drops. And when we prescribe drops, I think both patients and doctors, we kind of think, oh, drops are safer. Drops, you're going to have less problems with drops. Laser, that's serious, and we're going to have more problems. Look at this: 5 times less adverse events with SLT than there were with drops. In fact, in this particular study, and this was a really well done study, almost half the patients who took drops experienced some adverse event. Now, I think in this particular study, adverse events were sometimes defined, as significant injection. And so if you know with certain drops that you prescribe, that's these types of things happen. The point being is that we often think about laser as being much more significant in terms of adverse events. It's not, it's much less. And I think once we have that proper understanding, it kind of changes the way that we manage patients. In the field of optometry, there are now 11 states that allow optometrists some type of laser privileges, and so I think SLT is becoming more and more common. At 3 years, the SLT group were drop-free at almost 80% of all those patients. And then this is a really important factor as well, that in the SLT group, there were no surgical interventions needed. And in the eye drop grouping, there were 11. So big difference there. So should be, the light trial says should be, and I think we're seeing our SLT numbers increase, even though probably all of the glaucoma patients in the United States, only about 10 to 15% have had SLT, and that number should be significantly higher. Okay, so a study came out in 2017 that said looked at yearly SLTs and found that that may be a good thing to do, and that's more common practice in Europe. And certainly, I'm not suggesting that we go that far, but I am suggesting that SLT is not only suggesting, I'm saying that SLT is generally underutilized in the United States. So in this particular patient's case, we discussed the options with the patient. We decided to proceed with SLT. 1 month later, the pressure was 14.1 and 13.9, which was lower. Now, I often don't get better results from sending the patient for SLT versus a prostaglandin, but in this particular patient's case, we did, probably due to non-compliance more than anything else. And look what happened with this patient. So the first scan since SLT, and this was done probably 4 to 6 months after the SLT, is look at what we see here. Not only do we see stabilization, but we actually see improvement. And you say, well, we're always taught that glaucoma is a one-way street and it doesn't improve. Yeah, I think there's a couple factors to why we see an improvement here. One factor could be that you're having less pressure on pushing on the nerve fiber layer, so it allows that tissue to expand a little bit. And the other factor is that I think it's becoming more common within the field of glaucoma to realize that there are actually 3 stages of ganglion cell health. They're either they're either alive or they're dead, and that's what we were taught in school. But there's a third grouping where they are sick. And if you can intervene at the right time point by lowering pressure, that sick group will actually revert back to the healthy group. And so this, those 2 factors, mechanical and the sick ganglion cell issue, may explain why we actually see an increase in the thickness. But when you see that, you're on the right track in terms of treatment efficacy. And so this is the nerve fiber layer, and how about the ganglion cell complex? Well, we see a similar thing. This may be classified more as a stabilization rather than an improvement, but we're certainly seeing stabilization. So it's always nice to see that structurally when we after we do a treatment. And I would contend this isn't part of the presentation, but I would contend that we are. I would contend that we see early changes more so in technologies like OCTA and ERG. All right, so the pressure and the OCT were stabilized in this particular patient's case. And so is this your treatment paradigm as it comes to glaucoma management? Do you make the diagnosis, then add a prostaglandin? Well, many of us do. And then do we add maybe a second drop? And then maybe a third drop, or maybe one prostaglandin plus a combo drop. So there's a combination, there's a combined 3 medications there. And then do we think about SLT, and then MIGS, and then TRAB? So is this where your current SLT is in the process? So I would say that when it comes to personalized glaucoma management, always factor in noncompliance. In this case, this patient admitted to noncompliance, which is good, but most patients don't. But you always have to factor that in, particularly when you're seeing progression. Always factor that in, and then intervene at the earliest time that it makes sense in the risk-reward paradigm. In my case, I think we're probably doing 80 to 85% of newly diagnosed patients with glaucoma. We're going right to SLT, and that seems to work out really, really well for us. And when we talk about, as these patients kind of get worse and worse and worse and worse, jumping in with SLT in this area prevents so many patients from kind of moving up the scale there. All right, and now before we go into our next case, I want to just see if we have anything in the chat box. And okay, so I don't see any questions.
So Dr. Cymbor,
Yes,
so someone just said that they cannot type anything at the chat box. So probably if there is any questions, will be under the Q&A.
Oh, okay, gotcha. And so under the Q&A, where is the Q&A? So let me just get rid of the chat box. Okay, so I don't know where the Q&A is, so you might have to help me with that, Dr. Al-Naiman. So let me know if you see any questions in the Q&A.
Okay, I'll definitely will. Yeah, the only comment that I got was the chat box is not working.
Mm-hmm.
But yeah, I think we have a question now. Someone raised their hands. Let me see if I can find it. Yeah, I think we have a couple of questions, but now I'm trying to find them. Well, 2 people raised their hands, Dr. Moore and Dr. Hollands, but I'm not sure where they posted their question though. Let's see. Yeah, I will figure that out, Dr. Cymbor, as soon as I find it. Oh, I think I found it. Oh, I did find it, sorry. So for Dr. Baptisti, he said, these scans, have you see, I'm just not sure, have you see, sorry, the sentence is not complete. Okay, just as you have seen improvement in these scans, have you seen parallel improvement in visual field performance? That's from Dr. David Baptiste.
Yeah, so Dr. David Baptiste is a friend and classmate of mine, and so I really appreciate his question. Thank you, David. And so the question is yeah, when we see improvement structurally, what are we seeing in visual field? Are we seeing improvements? And I would say sometimes I am, although I would say probably more often than not, I'm not. But when we think about the OHTS study, it required a certain number of visual fields to be bad before they would actually call it a true glaucomatous visual field. And so when you look back at some of those visual fields, they would be reduced and then they would be better, and then they would be reduced and what they would be better. Some think that flickering of the visual fields, worse, better, worse, better, sometimes we chalk that up to variability, and I think that's reasonable to do so. But other times it's because, I think that maybe what we were seeing there is this sick cell concept, where it was, compromised, improved, compromised, improved based on pressure. So even though I don't typically see visual field improvements regularly, on occasion I do. I would say that, there's another technology I work with, ERG, I think is more sensitive to improvements. And so I would say more regularly, I am seeing improvements with ERG technology, the way that I see structurally. Also, OCTA technology, I'm seeing improvements. So thank you for the question.
Okay, great. So that's the only question for now. Thank you, Dr. Cymbor, and thank you, Dr. Baptiste, for the question.
Excellent. All right, so now let's move into our second case. So this was a 63-year-old white male referred to the Glaucoma Institute of State College. Corneal compensated pressures were 23.7 and 21.8. Patient was on brimonidine 0.5% and 0.5% timolol, both twice a day. Brimonidine and timolol. Was referred as an open angle patient, primary open angle. Grade 2 cataracts with some visual improvement, some visual involvement, and a cataract glare reduced to 20/50. Now, when we do gonio, you can kind of see here. Let me see if I can make that a little bit larger there. You can kind of see this angle is really kind of shut down here, really reduced. And looking at this angle, we can also see that the angle on OCT very, very narrow. So this actually isn't an open angle glaucoma patient at all. This is a chronic angle closure. We can kind of look at the optic nerves. These are the packs. It's thin packs. Optic nerve involvement in both eyes, and when we look at these visual fields, they are really devastating. Not only can we see how much of a tunnel effect we have. The mean defect is reduced to 22.6 in the right eye and 14.8, so we would classify those as severe in both eyes. And when we look at the OCT, this is right eye GCC and right eye nerve fiber layer. We can see the right eye is really just devastated, both infratemporally and supratemporally. Ganglion cell complex is all washed out. In the left eye, at least, we have a little bit of superior thickness, but infratemporally devastated and just not good. Just a really advanced visual field and OCT. So, careful angle inspection, allows us to see, wow, this is really, the mechanism is angle closure. The mechanism is probably not primary open angle. So it's worth having a quick discussion about primary angle closure classification. So primary angle closure suspect means you have greater than 180 degrees of iridotrabecular contact with normal pressure. So, most of your narrow angles are going to fall within this. You have true primary angle closure, which is greater than 180 degrees of contact with PAS, peripheral anterior synechia, or elevated IOP. And then greater than 180 degrees of iridotrabecular contact with PAS or elevated IOP and optic neuropathy puts us in the primary angle closure glaucoma patient. So primary angle closure suspect, primary angle closure, and then primary angle closure glaucoma. And remembering these as you evaluate these patients will really help clarify where they're at in the spectrum. There's a lot of mystery in glaucoma as it relates to angle closure, and just having an understanding of these three categories really, at least for me, helps simplify things. Here is a chart that is based on the Emanuel and Parrish's study in 2014. And so primary angle closure suspect here, primary angle closure here, or chronic angle closure, primary angle closure glaucoma or chronic angle closure glaucoma, and then acute angle closure. And so, this is a nice chart that really shows all the differences between these, between these pathologies, these grouping systems. So in this particular case, we would put the patient in the chronic angle closure glaucoma. There's greater than 180 degrees iridotrabecular contact. There is increased pressure. There is PAS, and there is glaucomatous optic neuropathy. So I have this on my website if you want to copy that or refer to it from time to time. This particular chart has been a big help to me, and I refer to it frequently. So when we think about the narrow angle or angle closure issue, it's really kind of a spectrum, where this is kind of like the least narrow, and this is the most narrow. And I always try to say, okay, where are they on the spectrum? Is this patient like just kind of entry level, maybe over here, so I place them in this end of the spectrum, or is this the most narrow angle that we've ever seen way over here? So in this particular patient's case, I would classify them kind of in this range, where they're definitely, definitely narrow, worse than average, but we've seen more narrow than that. I also like to look to see where the obstruction occurs. Is the obstruction mostly in the angle? Is the ciliary body causing the obstruction? Is it mostly the lens that's the mechanism here? There's so many patients that I would say fall into the number 3 category. Or is it something that's happening more posteriorly? Are they having choroidal effusion, choroidal swelling that is pushing everything up and causing the angle to close? So I really like to, I try to classify them into one of those four categories. So in this particular patient's case, what are we going to do to help resolve his glaucoma? Are we going to do a PI? Are we going to do cataract surgery? Maybe we should do cataract surgery and KDB goniotomy. Maybe we should do cataract surgery plus KDB goniotomy plus goniosynechial. So which of these three, which of these four should we do? Because a lot of people think, oh, narrow angle, let's go right to a PI. Maybe the EAGLE study can help us, can help elucidate this for us. So the EAGLE study compared LPI with clear lens extraction by looking at patients over 50 years old with mild to moderate primary angle closure glaucoma. So it's not an exact, our patient doesn't fall exactly into this category because the patient had visually significant cataracts. However, we can still use this information to our advantage. So, and what the EAGLE study found was a reduction in the need for further medications or glaucoma surgery in the clear lens extraction group. So it found that patients who you would go right to clear lens extraction need fewer medications or glaucoma surgeries down the road. They had a better quality of life, and this is important for insurance purposes, they found a better cost effectiveness over a 10-year period. So this patient is going to spend a lot less money, and in general, you're going to spend a lot less resources if you go right to clear lens extraction. But remember, these are patients that don't just have narrow angles. Don't be confused and say, oh yeah, because of the EAGLE study, I'm going to send all narrow angle patients and have clear lens extraction. That's not what the study is saying. The study is saying that if you have patients that fall in this category, primary angle closure glaucoma, glaucomatous optic neuropathy with one of these, then clear lens extraction found these results. So if a patient, with clear lens extraction, or excuse me, if a patient, that didn't have visually significant cataracts, it's found to be a really good treatment by going directly to cataract surgery, then obviously with visually significant cataracts like our patient had. Now, probably, wouldn't be to the point where we would normally send for cataract surgery, but considering the angle, yeah, I think it's completely reasonable to proceed to cataract surgery plus. And you might say to yourself, okay, well, you showed me a picture and you said that you showed where the angle was closed. How are you going to do a MIGS procedure like a KDB goniotomy when the angle is closed? And I'd say, yeah, you're absolutely right. We might not be able to. But when we talk about goniosynovial lysis, essentially what we're doing is after the cataract is removed and the iris opens, opens way up. It goes more posterior because there's much more space because, that natural lens is thick, it's cataract, the cataract is causing it to be, so thick. Once that's removed and the plastic lens is put into place, there's a lot more room, so that iris just kind of relaxes posteriorly. But we still have angle, an angle issue. Sometimes if there's no synechia, then that angle will open right up. But a lot of times, if they've had iridotrabecular contact for at least 6 months or longer, a lot of times it won't release. So with goniosynovial lysis, we can use just our KDB probe and just push down gently on the peripheral iris. So that's what our surgeon does. He pushes peripherally on the peripheral, gently on the peripheral iris, and in many times is able to break the synechia and open up that angle. Now, sometimes you can't, and you don't want to just keep pushing until you force it open, because that's going to cause, damage to the trabecular meshwork, and that's not going to be, any better by forcing it open. But if you can gently release the iris from the trabecular meshwork and open it up, well, then good things can happen. And that's what happened in this particular patient's case. This was pre-cataract surgery and pre-KDB, and this is post, where we look at the trabecular meshwork here, and now we see this white line right in here. And that white line represents what? It represents the back inner wall of Schlemm's canal. It represents the back inner wall of Schlemm's canal, so you can see it. So after a KDB goniotomy or goniotomy of any type, you should be able to see this white line right through trabecular meshwork. So, and then if we look objectively, this was pre-surgery, this was post-surgery. Look at how wide open that angle is at this point. So just a great surgical result. And then 2 years later, after this procedure, the patient's on no drops and the patient is completely controlled. So that makes us realize that the mechanism wasn't primary open angle at all. It was all in the angle. And unfortunately, you saw how bad those visual fields were. Had we been able to intervene at a sooner point, the patient would have been able to save a lot of visual field and nerve damage, essentially. So a couple gonio tips. Gonioscopy is, obviously can be a tricky thing. And so there are, one of these tips is as you, get your parallel pipe head image, and sometimes I orient myself from the bottom up. If I see the ciliary body and then I see the trabecular meshwork, then I'll kind of orient myself from the bottom up. But sometimes it can be difficult, particularly if the trabecular meshwork, has no pigmentation or very little pigmentation. It's easy to get lost. So a lot of times I'll orient myself from the top down. So where the parallel pipette, the light rays, you have this double light ray, which is the cornea. Once they merge, that's at Schwalbe's line. and then we know the trabecular meshwork is just, just kind of below that. So that helps me out a lot as I do gonioscopy. And look, I've done thousands of these, and still it can be confusing. And so that's one tip that I use often. Another tip is that sometimes compression gonioscopy is both needed to break an attack, but also helpful in determining PAS and your chances of of having a successful goniosynechial lysis. So a lot of times, and our interns know this, is I use two gonio lenses. I use a G4 lens that I'll use a little bit of coupling gel because that gives me really great clarity. But then I'll use my small footprint lens. So I'll first use my G4, and it allows me to get a great view of the angle, and then I'll switch and use my small footprint lens to push to kind of get a better sense of is it PAS, and is our goniosynechial lysis procedure going to work? And so I convey that to our surgeon and kind of say, hey, there's a lot of PAS. I think we have a good chance of goniosynechial lysis. So I let him know, and so he knows ahead of time going into the surgical procedure, hey, we're going to give it a shot. We might be able to break it, and we might not. It really depends on the tissue. Another gonio tip is synechia versus iris processes, and so here's synechia, here's iris processes, and sometimes it can be confusing, differentiating between the two. So compression gonioscopy really helps me out with that, and so as I press on the cornea with a small footprint, PAS, synechia are going to really become obvious there. And at least on a few cases, when patients present with an acute angle closure, we try to open them up by reducing the pressure, using all kinds of medications. But sometimes the pressure will not come down because of the iridotrabecular contact. So sometimes using a lot of force, a lot of force can then open that angle up and allow aqueous to start flowing. I think maybe another gonio tip is that here is OCT in scotopic conditions. You see the pupil is open. This is OCT of the angle in photopic conditions, and you can really see the difference between these two in terms of how open the angles are. And so a lot of times when you're doing gonioscopy, particularly if you're getting light in the pupil, but even if you're not, there's a lot of ambient light. And what's that doing to the angle? What's that light source doing to the angle? It's artificially opening that angle. And so, having an objective way to measure it, like an OCT angle, allows you to do it under scotopic conditions, really dim illumination. So you're getting, possibly a more accurate assessment. And so our surgeon and I had this raging discussion for several months, where I would see these really narrow angles here, and he would come in and do gonioscopy. And we'd be discussing the patient, and he would say, oh no, this angle's wide open. I thought you said it was narrow. And then I would show him this, and so finally he is now in agreement with me how useful scotopic measurement tools can be. Another gonio tip is that when you're doing gonioscopy, a lot of times you'll see this line here, which is a Sampaio-Lisi line. And that's kind of at Schwalbe's line. And you'll see that in two conditions, exfoliation or pseudoexfoliation and pigment dispersion. And so, so the trabecular meshwork actually is here. And so don't be confused when you see this line thinking that that may be trabecular meshwork. All right, and so personalized glaucoma management in this particular case always considers how the angle affects the disease. You assess the angle at least yearly, or whenever you start to see progression. You'll always want to make sure it's not a narrowing of the angle, because all of our glaucoma patients who have not yet had cataract surgery, all glaucoma patients who have had their natural lens in place, they're all going to narrow as time goes by. So they may start off having a true primary open angle mechanism, but you have to be so careful that they don't start developing a narrow angle mechanism that's contributing to it. And so, anytime you see progression, kind of reassess and say, when was the last time I did gonioscopy? You know what, I'm going to do that again. And always try to involve one subjective method, which is gonioscopy, and one objective method, such as OCT angle. Maybe you have a Scheimpflug imager more for cornea, but also can do angles. Maybe you have a B-scan that can do angles. Always try to do one objective measurement. All right, so any questions about case 2 and narrow angles?
I'm not seeing any questions yet, Dr. Cymbor.
Okay, thank you. So we've gone through, 2 of our ways where we can personalize glaucoma management, one being non-compliance and one being a narrow angle. So let's now move into our third. We have a 71-year-old white female who has type 2 diabetes. And in 2013, the patient came in for their regular exam and then saw one of our optometrists at Nittany Eye. And the pressures were 17 and 15. And the doctor noticed a bullseye appearance on the anterior surface of the lens and said, oh, you have a condition called pseudoexfoliation or exfoliation. The nomenclature starting to switch over to exfoliation more than pseudoexfoliation. And so you've got this condition that makes you a higher risk for developing glaucoma. So we need to get you back. Actually, they did an OCT same day. And so this was the OCT in the right eye. And we look at that and say, oh, that's pretty good ganglion cell complex. Not bad. Maybe we're seeing a little bit of thinning here in the right eye infratemporally. Now the bullseye, the exfoliation was just in the left eye. There were no signs of it in the right. And so the left eye, the eye we were more concerned about, shows pretty good ganglion cell complex, pretty good supratemporal and infratemporal. So we'd say, maybe there's pretty much minimal structural involvement there. That is great. But the doctor at that point said, okay, let's see you back in a month. We're going to do a more thorough, glaucoma workup, visual field, all of those things. And so the patient did not come for that visit. And the patient came again in 2015. So, kind of strolls in 2 years later. Fortunately, the pressures are good. And the doctor said, hey, you never showed up, for that visit. That you have a potentially blinding eye disease. You really need to come back in 2 weeks, and we have to do all of the, these things. And so the patient didn't show up for that visit again. So the doctor, fortunately and astutely, numerous calls, all this was documented in the record, sent letters, and then also sent a certified letter saying, hey, you need to come in for glaucoma testing. So the patient never came in again until 2017. And finally, the doctor at that point said, hey, why are you only coming in 2 years? We have all these, other things. You've got this potentially blinding eye disease. And of course, the patient said, well, that's how often my vision care, that's how often my vision care says I could see you. So this is one of the frustrating things that, we deal with on the front lines. So finally, in 2017, they did an OCT, a same-day OCT, and this is what the right eye looked like. Looks like we have more involvement, but look at this left eye. Oh my goodness, this looks terrible. So now in the left eye, infratemporal is just completely washed out. Supratemporal is reduced, and we have no, essentially no ganglion cell complex there. So quite a bit of asymmetry between the right eye and the left eye here. So the optometrist at that point began Lumigan in both eyes, and then sent the patient to see me. So as we look back in the right eye, we're seeing, again, right eye, no exfoliation that we could tell. And so we have pretty good, scans in the right eye as time goes by. Pretty good, very, very little change from baseline. Pretty stable progression analysis in the ganglion cell complex here and the nerve fiber layer, which is excellent. But look at the left eye. Look how devastating this is from 2013 to 2017. Just crashes and burns from here to here. And this is the danger of exfoliation. So we can't lump exfoliation into primary open angle that oftentimes is slow over the years. Exfoliation does not typically work that way. It is much more aggressive, and it can be like that dog that can go from being pleasant at one point to wanting to bite your arm off within seconds. And so this is really the visual that I think of when every time I see an exfoliation patient. This is what it can do. Very aggressive. And despite the fact that when we were looking at pressures over that time period, the pressures really never seemed to get out of whack. And so why, from between 2013 and 2017, if we never saw the pressures, if we never saw the pressures really increase, why did this happen? Well, we only have essentially 3 seconds over 4 years of pressures. And so we don't know what's happening, over a 24-hour period. So obviously the exfoliation was causing clogging and causing pressure spikes, and just causing devastation to that patient's left eye. Here are the nerves, and this is what we now have from a visual field. In that left eye, we are at an 18.8 on the mean deviation, just really a devastating visual field, as we would expect, seeing the structure change. So how are we going to manage this patient, at this point? Are we going to use mostly medical? Are we going to do laser, or should we do surgical, or maybe we should even do genetic testing? And we have to be really, really careful with cataract surgery when it comes to exfoliation, because you've got the exfoliation fibers, the exfoliation material affecting all these zonules, making the zonules really weak. And so, depending on who you are sending to for cataract surgery, you're going to need a surgeon in this particular case who has exceptional skill. Earlier on in my career, when we had more limited options in terms of ophthalmology presence, we would send patients essentially to 1 or 2 sources, and I would say that the surgical skill was about average. But on my exfoliation patients, I would see all these complications, and I never really understood why until I came to the realization that these exfoliation fibers affect the zonules. And so as you're in there kind of poking around, if you have a more of a heavy hand than you should, the zonules are going to break and cause all kind of problems. So you can have a small capsulorhexis, you can increase risk for phimosis, difficulty extracting the nucleus, capsular tears. These are all things that you can see more commonly in exfoliation with surgery. So all of the cataract surgery does have a tendency to lower the pressure more in cataract surgery than in non-exfoliation patients, including POAG. And so removing that lens, it can be a helpful thing. Why? We're not exactly sure, but maybe since a lot of these fibers come from the anterior surface of the lens, since you're getting rid of that, maybe that decreases exfoliation material liberation. Maybe the cataract surgery, kind of washes out the material from the trabecular meshwork and Schlemm's canal, pushes it further downstream. Maybe it deepens the anterior chamber, but it definitely is helpful. So maybe we should consider MIGS, Zen, trabs, and tubes. There's not a whole lot of data on MIGS and as it relates to exfoliation. There is some data from trabs and tubes, and all the data seems to suggest that these procedures are going to work better initially than the average patient. It's going to reduce the pressure a little bit more. And we also see that maybe with SLT as well, and even eye drops. But the result is not going to last as nearly as long, because you're going to have the fibers continue to build up even if you remove the lens. And I'll explain a little bit more about that in a moment. And maybe, a future therapy is gene transfer, maybe affecting, we know that the loxal gene is implicated with exfoliation, and maybe doing gene transfer can help out with that in the future. We're certainly not there at this point. So exfoliation is, and we say this a lot, is the type of glaucoma that's going to try to make me look bad. So we try to set our patients' expectations properly, where we say, hey, you have the most aggressive form of glaucoma, and it's going to continually try to fight me. And it's going, your pressure is going to be increasing at certain times. So you want to set them up for the understanding that, some of our glaucoma patients, when their pressure goes up, they're so disappointed and they get depressed and all those things. So I think it's good to set the stage with these particular patients, giving them a proper, understanding of where they're at and what's going to happen in the future. And then when they understand that this is a really aggressive glaucoma, and they come in one time and their pressure is high, they don't necessarily view it as a failure on your part or the treatment's part. They view it as normal part and parcel for exfoliation. And they also are more inclined maybe to keep their follow-up appointments, not like in this patient's case. Be careful, because exfoliation is #1 in glaucoma-related lawsuits, and so most glaucoma lawsuits is due to exfoliation, and so the stakes are certainly high in these particular patients' cases, and so it affects 70 million people worldwide. 20% of all glaucoma is exfoliation. And this is a startling percentage. This is the one that really hits home for me. 30 to 50% of patients with exfoliation will develop glaucoma. 30 to 50%. So how many times do we see these, the bullseye lesion in our office, and we're like, yeah, you have a slightly increased risk, but no big deal. We'll see you in a year. No, it shouldn't be like that. It should be, hey, you have a really significant risk factor for glaucoma, and we're going to follow you on a 6-month basis. And we need to make sure that you're not developing this glaucoma, because it can move really rapidly. There were some well-recognized ocular targets like the bullseye that we talked about, but you can also see the fibers often on the pupillary frill. And maybe here's a clinical take-home is that, what if the patient's had cataract surgery? Now you're seeing this patient for the first time, and they're like, yeah, I have glaucoma, and they just tell you that, and you're kind of thinking, well, they probably have primary open angle. But a careful inspection of the iris margin, a lot of times you'll see these flaky white fibers even years after cataract surgery, and then you can kind of tell, oh my goodness, yeah, they have exfoliation. We need to be really careful. These fibers not only go from the lens to the trabecular meshwork, they also form inherently in the trabecular meshwork. And that's why cataract surgery, you just can't do cataract surgery and the condition is cured forever. A lot of times the fibers will inherently build up in the trabecular meshwork. All right. And also the lamina cribrosa. It's thought that the fibers affect the lamina cribrosa and weaken it structurally, which may contribute to glaucoma, and that's why it can move so quickly. You know, the structures supporting the neurons, they don't work quite as well. They don't have quite that strength. Exfoliation fibers can also build up on the endothelium, so you have to be careful about that. And then the ciliary body as well. So if you're thinking about a procedure like ECP, where you're lasering the ciliary body, you need a lot more energy, a lot more time to get the same result because of these flaky fibers building up. Transillumination, it affects the iris a little closer to the pupil. It's, you know, you can differentiate pigmentary glaucoma versus exfoliation by where you see the transillumination defects. In exfoliation, it's a lot closer to the iris. The pigment dispersion is much more peripheral. Again, Sampeio-Lisi line that we talked about. So personalized glaucoma management in patients with exfoliation. We recognize it as one of the most aggressive of the glaucomas. We manage it accordingly. We discuss the importance of sibling evaluation. So, you know, if you see a patient with exfoliation and definitely exfoliative glaucoma, you say to yourself, hey, do you have any siblings, brothers or sisters? Yes, I do. I have 2 brothers and a sister. Okay, make sure that they're getting evaluated. And I'm going to write down something for you, and I'll write, you know, pseudo-exfoliation or exfoliation, and I'll hand it to them, and I'll say, give that to your brother or sister, and when they go in and get their eyes checked, hand them, you know, have them show that to the eye doctor. In the hopes that that will raise that type of awareness. And follow suspects every 6 months. So even in patients that I've been following for years that have no signs of glaucomatous optic neuropathy, I'm following them every 6 months. All right, any questions about exfoliation in that third case? All right, hearing none, we will move on. Okay, 55-year-old Hispanic male referred to the Glaucoma Institute of State College, referred with pigmentary glaucoma in the right eye, medicated with Lumigan and Comigan, and corneal compensated IOPs were 47.2. So 47.2 on Lumigan and Comigan. Left eye doesn't seem to be involved, thin packs, super low hysteresis in that right eye. That's super low, even low in the left eye, but super low in the left. So big risk factors all over the place there. And so we can see in the right eye that there is definitely some asymmetry compared to the left. So it appears like there is significant glaucomatous optic neuropathy. We see the Krukenberg spindles, quite a bit of pigmentation, all over the place here. Surprisingly, the visual field, while affected, with this inferior nasal step, perhaps a little bit of a superior arcuate, actually is not bad. You know, I would classify it as moderate based on HAP criteria, but I really expected a lot worse than that. In the left eye, essentially unaffected. So as we look at the OCTs in the right eye, we see that the ganglion cell complex is definitely affected. Supratemporal, infratemporal, definitely reduced here. The left eye seems to show no involvement. So in this particular patient's case, we say, yes, we agree this is pigment dispersion, pigmentary glaucoma that is really acting up, really getting aggressive. So we proceeded with next day SLT, and this was kind of at the request of our surgeon, and we had the discussion, and he said, yeah, let's do SLT tomorrow, and kind of get it taken care of that way. I said, really, SLT the next day? You want to do SLT on this? because I was thinking you would have to get much more aggressive. So 2 months later, the pressure is now in the high teens, low 20s. Patient's still on medications, but the pressure came down beautifully. So about a year and a half later, the pressure starts increasing again into the 30s. So we adjust the medications, probably did an SLT again. And then 2 years later, pressures hit 40. I mean, this is 1.5 years later, so 2 years after this, so another half year, another 6 months, pressure continues to increase despite our best efforts. And just a brief introduction to OCTA angiography. This, is a perfusion chart, so we like to see these lighter colors. These darker colors mean non-perfusion. So perfusion, non-perfusion. So we can see in the left eye, we have really good perfusion at baseline, really good perfusion afterwards. Right eye, we can see not great perfusion at baseline, even worse follow-up, and we're actually seeing a trend of worsening perfusion in the right eye. So what are we going to do at this point with this patient? We're going to send, should we send, the patient for a trab? I was thinking at that point, this patient's definitely going to need a trab. And in the right eye, maybe some type of MIGS procedure in the left eye. So the surgeon said, we sent the patient to Will's in Philadelphia. The surgeon was Dr. Moster, who was exceptional. And she said, hey, we're gonna go in here trying to do GATT. And if that goes well, that may be all that we need. If it doesn't, then we're gonna do a trab. As it turns out, she performed a GATT successfully. And 1 year later, the pressures are now really, really well combined on Combigan twice a day. So briefly about a GATT procedure. It's essentially unroofing the trabecular meshwork 360, injecting some fluid, trying to push all that pigment pigment buildup further downstream through Schlemm's canal into the collector channels. And in this case, it really worked. It worked beautifully. I was really surprised. I thought this patient was going to need a trab. And 1 year later, patient's still well controlled. So a great response. So now I think about, when it comes to pigment dispersion and exfoliation in particular, we think about GATT or some of the similar surgeries that inject fluid and try to force everything downstream. Here's another example of pigment dispersion that I see more frequently. You look at the iris configuration here. Is this pupillary block? Well, it's not pupillary block. That's when the iris structure is kind of more the opposite way. So this is reverse pupillary block, and it's thought that patients with this iris configuration, you're gonna have a little more rubbing, on the iris in the mid-periphery between the iris and the lens. So what do we do with these particular patients? Well, I would say that in many cases we'll try a PI, and the research is all over the map when it comes to what to do with these particular patients. But what I find is PIs, oftentimes you can equalize this iris configuration. You can really flatten out this iris configuration. So I do have examples of. So when I see it, that involved, then oftentimes we will do a PI, and oftentimes we're going to see that, kind of flatten out. So be aware of that when it comes to pigment dispersion. So we can do medical treatment. Some people advocate pilocarpine, to try to change that iris configuration. But you can use any of these medications. In fact, there have been cases of patients who have some type of pupillary block, and using pilocarpine on a regular basis can reverse that. And so SLT can be very effective, as we saw in this case, but you have to be a little bit more careful when doing SLT, because the trabecular meshwork can become just completely overwhelmed. It can eventually become overwhelmed, meaning you get all this pigment thrown in there, and the trabecular meshwork is trying to clear off this pigment. White blood cells are trying to phagocytize this excessive pigment, and it can keep up to some extent, but eventually it can cause scarring. And so you may have a really great result one time of doing SLT, but eventually you may hit that that point where the trabecular meshwork essentially just kind of shuts down, and you may have a huge pressure spike after SLT. So you have to be really, really careful about that. So some doctors will reduce the energy of as they're doing SLT, and that can be helpful. MIGS is really helpful. GATT is explained here. KDB, procedures like that can be super helpful, but you may need to go to TRABs in more aggressive cases. So personalized glaucoma management of pigmentary glaucoma recognizes pigment dispersion as one of the most aggressive of the glaucomas and understands the ticking time bomb nature of the disease. So I think both exfoliation and pigmentary glaucoma are two super, super aggressive glaucomas that need to be managed much more cautiously and frequently than most of the glaucomas. Any questions at this point?
I have a question, Dr. Cymbor.
Please.
Okay, so it's just a naive question. When I see a glaucoma suspect, I always refer them.
Yeah.
But let's say you're in a clinic that you cannot measure the cornea thickness and you don't have an OCT. And let's say the IOP is around 24, but the visual field is normal, the screening visual field is normal. Would I still have to refer?
So, I think let me try to restate the question and see if I have it right. You're saying if a patient is a glaucoma suspect and has pressures of like a 24 and no visual field defect and no apparent optic neuropathy, should you refer?
Yes.
Well, yeah, that's an excellent, that's a really good question. So for me, like at that stage of the game, having a baseline OCT is so important for my management. So I would say, so I think it would be reasonable, to refer to someone who has that type of baseline information. And even if you don't, I think it's reasonable to refer to another optometrist or ophthalmologist just for that particular scan. In fact, there are optometrists that utilize our OCT that way. It's a lot more in the past when OCT technology was newer. So I had several optometrists that were referring patients in just for OCTs, and we would not, interpret, we would not be part of it. They would, and so they would submit for the interpretation, we would submit for the technical component. So you can actually break up the OCTs that way. So I would recommend for you at that point, find an OCT, someone who has an OCT, and send them for a baseline. I think that would be a really good thing, because there's so many times where I would look at a patient and say, oh, their nerve actually looks pretty good. And we would do a screening visual field that came out normal. And then I would read the OCT and it's like, wow, it has a lot more, there's a lot more going on than I could tell clinically. So I'd say with a pressure of 24, clean visual field, apparently no optic neuropathy, I would still send for an OCT. I don't think you necessarily have to refer the patient so you'll never see them again, but possibly, possibly get a baseline OCT.
So the cutoff will be 24 or even 22?
So there's no cutoff. I
Okay.
can't, I can't give you a hard and fast number. For example, this exfoliation patient that I presented earlier, their pressure never got above 19. So I would say certainly at a pressure of 24, I think I would do that. I would say, that is the $1 million question, and there's no number that I can give you. I would say that if it was a pressure of 19, like in the exfoliation patient case, we would have all gotten burned. So I would say medico legally, anything above a 22 needs careful consideration.
The problem is, as you said, like you need gonio, but what if you're busy and you cannot do gonio?
Yeah. So I actually like objective measurements as much or more than gonio. And so if sometimes when I'm in a pinch with time, if I have an objective OCT, so an OCT angle or a Scheimpflug angle, and that's super wide open, then that always makes me feel good. Oftentimes I'm doing both, but in a pinch, having an objective method. Now, the other thing is that a careful von Erich assessment will give you so much information, and so don't forget about don't forget about von Erich, that all we need is a slit lamp
Yes, that's a good one.
Yeah.
Thank you.
You're welcome.
Thank you
For the question. All right, if there are no other questions, we'll move on to the next case. So 65-year-old white female saw their local ophthalmologist in the past, hasn't seen an eye doctor in a year. The patient was diagnosed with mild primary open-angle glaucoma in the right eye, using Vyzulta in the right eye. Right eye is always red. So the patient just stopped using the drop about a year ago. Patient has COPD, asthma, sinus issues, oral steroid usage 3 to 4 times a year. And the best corrected visual acuity is 23 in the right eye, and left eye, grade 1 nuclear sclerosis. So the patient comes in, sees me, cornea corrected IOP of 26.9 and 21.2, PACS 591 and 599, so nice thick PACS. Corneal hysteresis is somewhat asymmetric, right eye versus the left, statistically normal but asymmetric. And we did an inflammatory, and it was positive in both eyes, indicating a significant amount of MMP9 and inflammation of the ocular surface. So we go ahead and do OCTs, and the right eye, this seems to be reduced. However, it's really symmetric, and so anytime I see this kind of symmetry, I'm not quite as concerned as with asymmetry. And although infratemporally we are being flagged versus the normative database, in the left eye we have pretty good thickness, supratemp and infratemp. However, infratemp is being flagged. And however, we see really good symmetry here on the Tisnet plot, really good symmetry. And so, so I'm not that concerned about these OCTs. When we look at the fields, I would say that these fields look pretty good. Really low mean deviation. Oftentimes you're not gonna. Glaucoma doesn't really do this. Maybe we're seeing a spot here. Maybe we're seeing a spot here. But it's the first fields that we've done on that particular instrument. So I'd say those are pretty good. When we look at OCTA, I like to see 50 in these. So these are definitely reduced. So we are seeing some perfusion reduction there in the right eye. Left eye, still some perfusion reduction, but much better perfusion in the left eye. And so let's see, yeah. So we ended up, diagnosing steroid. Oh, and so I want to, just kind of make it clear that this patient was on steroids 3 to 4 years, 3 or 4 times a year, and was on recently to this. So we did perform SLT on this patient. We diagnosed the patient with steroid-induced glaucoma. And so we did the SLT, and we felt like the pressure was reduced with SLT. And we said, hey, the next time that you are on an oral steroid, I want you to just stop by the office and let's check your pressure. So the pressure 6 days in to her next round of oral steroid usage due to her lung issues, 6 days in on oral steroids, 36 and 25. And then we say to ourselves, aha, that's the key to this. This is what's happening, is that even with SLT, imagine what these numbers would be without SLT. Imagine what those numbers have been in the past. And so, we can kind of see now, going back, we can see that, yeah, we definitely have some perfusion, and even though those OCTs, are symmetric, and which is good, they are reduced. But interestingly enough, they're reduced in a symmetric kind of way. So the steroid mechanism affects the nerve, a little different than the primary open angle mechanism. And so, so what we started doing is we would put the patient on topical carbonic anhydrase inhibitors 3 times a day during oral steroid usage. And that brought the pressure down during the treatment of oral steroids into a much safer range. And so SLT, SLT, selective laser trabeculoplasty, is effective. You may need them a little bit more often. A TRAB certainly effective, and there are many other things effective. But essentially, essentially what and I just want to make sure I know exactly where we are at here. Okay, and so essentially, the mechanism is when this patient's on oral steroids or steroids of any type, her pressures shoot up. And so that's what was causing the damage previously. SLT was a big help, but we realized that it wasn't enough. SLT wasn't enough to prevent ongoing compromise and damage. So using a carbonic anhydrase inhibitor, in addition, while she's undergoing these treatments, and we usually now start it immediately as soon as she's on the steroids, and we stop it usually a week or 2 after the steroids are done. That combination of SLT and carbonic anhydrase inhibitors really work well for this particular patient. And so I think the way to personalize their glaucoma treatment is getting them on something that's going to reduce the pressure. So the SLT is a really nice thing because it reduces pressure 24/7, but it's not enough to prevent some spikes while she's on treatment. So using a combination of SLT and an additional eye drop seems to be the best combination for her. I think probably you could use a prostaglandin, 20, every day, and using the carbonic anhydrase inhibitor on top of the prostaglandin, but this was a really effective way as well. So steroid-induced glaucoma, and also be careful because I had one patient who we realized this about their oral steroids, but then had an injection, and like a knee injection of steroid because of arthritis or something. And the patient came in. It just so happened the patient came in shortly after that injection. Their pressure was out of control, and I said, "Oh, your pressure's up today." And the patient said, yeah, I'm not on oral steroids. I don't know why that is. And then the patient just kind of thought about it and said, oh, I did have an injection in my knee a couple weeks ago. And we realized that it was a steroid. And so we had that conversation. Hey, you have to be really careful with any types of steroids in your body. They're going to cause them to, they're going to cause your pressures to go crazy. All right, next case. We have a 66-year-old white male referred to the Glaucoma Institute because of asymmetric pressures reported at 15 and 25. History of trauma in that left eye 25 years ago. Pressures, corneal compensated IOP, 16.5 in the right eye, 27.2. Corneal hysteresis is 12.3 in the right eye and 9.7 in the left eye. PAX 590, 592, so nice and thick. Good hysteresis in the right eye, bad in the left eye, asymmetric cup to disc. And so we look at the regular OCTs, the conventional OCTs, and we say right eye looks good. It's being flagged here, but essentially I'd say that that looks really good, pretty good symmetry. Left eye looks great. With the higher pressure, there is this one little blip here, but that doesn't look like glaucoma. So I'd say structurally is good. Functionally, these are as clean visual fields as you will ever see. So we felt pretty good about that. However, using OCTA technology here is showing that over time we are losing perfusion in the left eye. And that's the only test that really showed it at that point. Was the OCT was showing that left eye trending downward. So that made us realize we have to do something here, and we can kind of see that taking effect. And so at that point, we felt really, really good. So OCTA is complementary to conventional OCT, and a lot of times you'll see things prior to change on conventional OCT, and fortunately we saw that in this particular patient's case, and so we were able to act. So we diagnosed traumatic glaucoma, with a little bit of angle recession. So you'll see angle recession, and the ciliary body will look really, really large because the iris has been kind of ripped away from that. Now, sometimes you won't. Sometimes you won't see angle recession. Sometimes the angle will look normal. But with a history of trauma, that shock wave can still damage the trabecular meshwork over time. So you might not see it until 20 or 30 years later. So any patient that has a history of trauma, oh yeah, I was punched in that right eye, I had to go see the doctor and they said there was a little bit of bleeding, and that, those types of histories should get your glaucoma radar on full alert and follow them a little more frequently. So pilocarpine and SLT, is kind of contraindicated, but you can perform low energy SLT in the unaffected sectors. And so, you're not going to do it in the angle recession area, obviously, but the part that's not angle recessed, you can still do it on. But even in a history of trauma, you want to be careful about it. TRAB is certainly effective. Eye drops are effective. And so, you have to be really, really careful about SLT. But that said, we have a handful of patients that we did low energy, small areas SLT that have turned out really, really good. So you can do it, just be cautious about it. But I guess the take home there is, in a history of trauma, just make sure you're not missing anything. All right, coming down the home stretch, and we have a 67-year-old white female, history of recurrent uveitis, has at least 10 episodes of recurrent uveitis. Pressure will increase if the anterior reaction is significant or a steroid is used. So, and this has caused the pressure to increase at times to 48. So these can be really tough, these recurrent uveitis patients, because, if the uveitis is uncontrolled, the pressure increases. If you treat them with a steroid, the pressure increases. It's like, how are we going to fix this? And some patients get extremely frustrated. Some doctors, some clinicians get extremely frustrated. Hacks were 620 and 617, hysteresis good, mild nasal step, and then minimal OCT loss, but definitely some. And so, this is like, Groundhog Day, where you start the inflammation, starts up, and so that causes the pressure to increase. Then you throw on a steroid, and then and then that can cause the pressure to increase. So the green area, the green arrow is the pred. This is when you put pred in, and then red arrow is the IOP reducer. So the patient would develop inflammation. The inflammation would cause the pressure to increase. So the sign X is let's see, the sign X is the pressure. Okay, so as inflammation would go up here, the pressure would initially go down, but then the inflammation would get worse, and then you would throw on the pred right about here, and the pred would then cause the pressure to continue to go up, because now you're adding pred, and then you throw in the pressure reducer. So this chart may have been overly complex, but essentially what we're saying is, with Groundhog Day, it's the same thing over and over and over, but you would run into this vicious cycle where you would treat with pred, you would get the inflammation down, but then the pressure would go crazy, and then you start to treat with a pressure reducer, and that would help, that would be fine, and all those things are good. But is there a better way? Is there a better way than just treating the episodes? And the answer is yes. We were able to stabilize her with 0.5% timolol every morning and 1% pred forte every other day. So that was basically the least amount of treatment that would stabilize her. So, instead of, not doing anything and just letting these episodes, these recurrent episodes happen, we were able to stabilize her with 0.5% timolol every day and 1% every other day. And it took us a while to kind of figure out that was the right issue. And so now the corneal compensated IOP is nice and low, and she has absolutely no progression in 3 years using this. And she's had no uveitis, episodes in that amount of time. In fact, there was about 1.5 years where we didn't see her. And I thought, oh, what happened? Did she go somewhere else? She came back in after 1.5 years, and I said, hey, where have you been? She said, my husband was really sick, and I had to take care of him, and I couldn't focus on anything else. And I said, well, did you keep up with your drops? She said, yeah, I kept up with my drops for the whole 1.5 years, and I had no red eye episodes. So fortunately, we found out, before her husband got sick, that this was the right thing for her. Now, it's not always the right thing for all these patients, but with these patients who have these recurrent uveitis flares, and they develop glaucoma, this was magic for her. Sometimes we need the pred forte every day. Sometimes we'll use Lotamax as part of the regimen. Sometimes we'll need more than 0.5% timolol. Sometimes we need other medications, but in her case, we found that equilibrium, and that was a beautiful thing. So you always have to weigh the inflammation versus the IOP and try to find that that system that works out best for her. Trabs and tubes are effective. PIs might close. They can be reopened. Sometimes a surgical iridotomy is necessary. So I think we're coming up on kind of the end. Let me just do one quick case that is kind of interesting, and we saw a similar one yesterday, where 4-year-old white male, type 2 diabetes for 15 years. IOP is typically in the mid-teens. and was on 0.5% timolol, had proliferative diabetic retinopathy, ongoing injections, had PRP, and so was having regular injections. And this patient was just like we've used the term ticking time bomb before, but this patient was kind of fed up with all of his diabetic treatments, fed up with all his eye treatments, and just said, I've had it. I'm not doing any of this. So a couple months went by, and then he comes in with pressures that are now out of control. And so we see neovascularization of the iris, and we see now the neovascularization of the angle. And this is what we had yesterday. We had a patient with hyphema, neovascularization of the retina, and so we had to stabilize the pressure. So just like yesterday, we stabilized the pressure using Comagan, Rocklatan, Diamox. We have to be a little more careful with using Diamox in patients with diabetes. So we referred the patient. The most important thing is getting the patient for an Avastin injection as soon as possible. In this particular case from yesterday, we have the patient scheduled for Tuesday. So we stabilized the pressure, got the pressure down. 2 days later, the pressure was, in this particular case, was reduced, and eventually, once we took care of the pressure acutely and the patient got an injection, we realized that we have to be more aggressive in this particular case. And topical drops are going to do it temporarily, but it won't work long term. So we eventually, in this patient, got the patient to have a trab with mitomycin, and that has worked out really, really well. 1 year later, pressure was reduced, and so the patient is in pretty good shape. So anti-VEGF, use it initially, must be followed by extensive PRP. Tubes are more effective than trabs in these patients usually, and so I think that is a good place to end. We hit 1 hour and 40 minutes, so we've met our COPE requirements. And so are there any other questions at this point that I can answer before I finish my presentation?
We only had a comment. Thank you for a fine presentation. This was from Dr. Garalo.
Thank you. Thank you very much for those kind words. I really appreciate it. I enjoyed spending time with you today. Again, if you need to reach out further about any questions from today or anything you see in clinic over the next next week or so, feel free to reach out. Always happy to share my information. Always posting stuff on LinkedIn as well, so feel free to to communicate with me that way. So thank you very much for your attention, Dr. Al-Naimi. Always a pleasure. Thank you for being, allowing me to be a part of this, and I look forward to listening to your lectures soon.
Thank you very much, Dr. Cymbor. I really appreciate you being here today. You're very welcome. Thank you, everyone. So we'll take a break and we will resume at 10 a.m.